and Métis people. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. We extend this acknowledgement to the lands where each of you are joining from. You are welcome to share your land acknowledgement in the chat box. Now, joining me today are three incredibly dynamic speakers. First, we have Susan McKenzie. Susan is a communication and a fundraising professional. An unknown genetic form of kidney disease affected Susan's family for 4 generations. Her father, herself, and her middle daughter have all had kidney transplants. Since her transplant, she has worked to support kidney patients and living donors in many different capacities, including by co-founding and overseeing the Transplant Ambassador Program and by being an active volunteer in the community. Next, we have Dr. Anne Young. Dr. Young is a nephrologist who also has a PhD in clinical epidemiology and health services research. She is now an assistant professor and clinician investigator in the Division of Nephrology, Department of Medicine at St. Mike's and the University of Toronto. Her research focuses on strengthening health service delivery for patients with chronic kidney disease. Then we have Nadia Remtulla. Nadia is the Privacy Director with Ontario Health, where she's responsible for privacy legislative compliance, promoting effective data governance, and advising on privacy risk management strategies. Nadia has more than 10 years of privacy experience specializing in compliance with Ontario's privacy and access legislation. Joining the conversation as well is Dr. Amit Garg. Dr. Garg is Senior Scientist and ICS Kidney Dialysis and Transplantation Program Lead. Dr. Garg is nephrologist at the London Health Sciences Centre, where he provides care and conducts research to improve health outcomes for patients with kidney disease, including those receiving dialysis or kidney transplant. So before turning it over to the panelists, let me first begin by providing a bit of context for why ICS prepared a report on the topic of privacy legislation modernization and its relevance for a data-driven health system. ICS is a not-for-profit corporation whose mission is translating data into trusted evidence that makes policy and healthcare better and people healthier. We are able to accomplish our mission due to a special designation in the Personal Health Information Protection Act, otherwise known as PHIPA, that permits health information custodians to disclose personal health information of patients to ICS without consent for the purpose of population-based analytics. ICS scientists also conduct research. In exchange for statutory authority, we are subject to oversight by the Information and Privacy Commissioner of Ontario. Over the past 30 years, we have established administrative health databases that have helped to inform government policymaking. Late last year, we were informed by the Ministry of Health that they were conducting a broad consultation on PHIPA modernization. We decided to participate in the consultation for the following 3 reasons. 1, we know that since PHIPA's enactment in 2004, Ontario's health system has seen increased integration of health services and a proliferation of health technologies that produce mass quantities of digital health data. We fully believe that an accurate portrait of a patient's care journey can be achieved through seamless and data sharing across an integrated care continuum. Similar seamlessness with data sharing is needed at the system and population levels to provide timely and accurate analytics and research on the health system itself. Therefore, thirdly, we know that any modernization efforts to PHIPA require support for a robust analytics and research framework that can both anticipate and authorize the necessary conditions for the use of digital health data. To maintain trust in the health system, of course, we need to ensure that whatever framework is implemented must continue to maintain the privacy and confidentiality of the individuals who are the subject of the data. By modernizing PHIPA, it will contribute to the vision of improved health and healthcare delivery for everybody through world-leading research and analytics. As a result, we submitted a detailed written submission and with the help of ICS's Public Advisory Council, turned the submission into a thought leadership report. Indeed, the goal of the report and the goal of the webinar is for us to really think outside the box, to be creative and to consider how can we truly achieve a data-driven health system. We decided to focus on 2 of the recommendations in the report, the focus on the matter of using analytic data to re-identify patients for healthcare delivery purposes, and on the topic of patient context studies. We will be introducing a number of concepts. Some of you may have deep knowledge about the subject matter, and some of you will be hearing about these concepts for the first time. In all instances, we invite you to ask questions or provide comments in the chat. I will be moderating the session today. We will first begin with Susan, who will provide the perspective of a patient living with kidney disease. Then she will turn it over to Dr. Young, who will introduce a research project that aims to improve aspects of the health system involving the prescribed entity model. Then to Nadia, who will provide an overview of the privacy legal framework for prescribed entities. And finally to Dr. Young, who will describe some of the challenges in more detail. I will then ask a few questions and we will leave approximately 15 to 20 minutes for audience questions. We are really hoping that this dialogue stimulates discussion and curiosity into the concepts that we have presented and perhaps even ignite change at the statutory level. So with that, I'll turn it over to Susan.
Hi, everybody, and thank you so much. It's really wonderful to be here, and I'm excited to be kicking this off as a patient. I think it really speaks to how patient-centered this work is and how important it is to patients. So Rosario already introduced me, gave you a little bit of my background. When I had my kidney transplant, which was in 2010, I had been followed for already 12 years. And I did have the benefit of being able to have kidney-friendly medication that helped to delay the onset or the progression of my kidney disease. And I was extremely fortunate in that. I did end up needing a kidney transplant after 12 years. And I was very close to having a preemptive transplant before dialysis. It wasn't able to happen, but I got very close to having the best possible outcomes that a kidney patient can have. At the time that I had my transplant, we did not yet know in our family that our kidney disease was 100% genetic. We knew that there was a really strong history. As Rosario mentioned, my father, my grandfather, 4 of my uncles, there was a really strong family history of kidney disease. But we had been given throughout the years many reasons why there's so many people in the family that had it. And it was, genetics was not necessarily at the top of the list when we were younger. And when my daughter had her transplant, she was diagnosed in her early 20s. She was able to get the very best and optimal outcome, which was preemptive before dialysis kidney transplant from a living donor. And she was able to have 2 children, 2 small, so they're now 3 and 2. You can see them at the, you can't see them at the bottom. There they are at the bottom of this slide, in the middle. That's Liam and Connor. And what we now know that was discovered actually after Liam was born, just in 2020, is that it is a rare genetic gene called MUC1 or mucin1, and it's autosomal dominant in that it's passed on to 50% of the children who have the gene. In 2020, we finally learned, even though there was this really strong family history, that 2 of my children, my 3 daughters, have the gene, and those are my daughters on the left. The daughter in the middle managed to escape the gene, and the other 2 are one has had the transplant, and the other is in probably 3rd stage kidney disease. But again, because we're very aware of it, we can hopefully get some pretty solid outcomes, hopefully. That's my kidney donor, by the way, on the right. I just always have to give her a little bit of, that's Marianne. She is my husband's sister. Because at the time that I had my transplant, we didn't know what the gene was. No one in my family could be considered, anyone in my bloodline could be considered as a potential donor. So that made things a little bit more awkward as well. I think what my experience as a patient was pretty normal, but I think my approach to it was not very normal. I'm a very proactive person, and I knew that even though it hadn't been diagnosed as genetic 100%, I knew that we had this strong family history, and I was going to be proactive. I was going to hopefully avoid getting this gene and having to be on dialysis and having to have a transplant. And so from the very early days in my 20s, I would ask my GP, can you check my kidneys? Can you check my kidneys? And he never really wanted to. He always thought I was really healthy, that I didn't need my kidneys checked. And I remember asking him for 4 or 5 years before he finally reluctantly referred me to a GP, or sorry, to a nephrologist. And when I remember going to the nephrologist thinking that I was really wasting a lot of people's time, and he, on my first meeting, informed me that I did have genetic chronic kidney disease. So, had I not been quite so proactive, I may not have had those 12 years with some renal, friendly therapies to help me delay and get prepared and let my family members know that I may need a donor, all of those kinds of things. Um, and so that was really quite positive from that perspective, making the best of a difficult situation. But what I know, what I experienced, my approach is not normal, as I mentioned. Even my own siblings did not want to know. They did not want to get tested. They did not want to know if they had this gene. Most of the people in my family did not want to know. And I also know from our work in the Transplant Ambassador program that that most patients don't. They kind of feel like this is this idea that the philosopher John Locke came up with many years ago. If I, that I don't have it as long as nobody tells me that I have it, is a pretty is a kind of a way that people like to go through life, but it's not a very productive one. If I don't acknowledge it, it doesn't exist. And I think because kidney disease, the 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 symptoms of kidney disease are very benign. They call them silent. They are, and for me and for many patients that I speak to, it's about being tired, lethargic, kind of getting a little bit of nausea, and that those symptoms that just become more severe over time. But because you again get used to them over time, you're often not seeking a doctor's support. And I think it is really truly kidney disease is really the perfect storm of allowing patients to be in denial for a very long time, which is why potentially why emergency dialysis starts are still at about 30%. So for those reasons, I think that this study is such an exciting study that you're going to hear about. My approach, which again was not that I think is abnormal in terms of being very proactive, um, based on my family's experience and based on all of our experiences with the Transplant Ambassador program that that started in 2016, and we've had over 7,000 conversations. We have 200 ambassadors who are transplant recipients or living donors. And we know that the common response is not to do very much about it. But because there are, and even my transplant was 13 years ago, and there were some medications that could delay my progression of my disease. It is, the medications and treatments have advanced so much even in the last 5 years that knowing early can really make a big difference to your outcome. Having and that's what we really want to get across to other patients in our Transplant Ambassador program. That's how my family has had good outcomes by being proactive about getting the care. But that's also why it's so important that the system is proactive in terms of also ensuring that patients get the care they need and understand that there are treatments out there, and that kidney disease does not have to be, a deadly disease, that you can actually have a really great life. And hopefully your kidney disease is detected before you need renal replacement therapy like dialysis or transplant. And I think this whole project is all about that. But if you do need a transplant, that your life can be extremely fulfilling and positive, and you can do all the sky diving that you want to do as long as you're proactive about it. You can really dramatically increase your outcomes by knowing about this disease early, and I think that's our message to patients, and it's also our message to the system and to caregivers, is that the earlier we can possibly know about this, the better, and the stronger people we can be. There's something really positive about understanding your own mortality and really embracing every moment and every day of your life, and it's kind of a good way to live for all of us. So that's really at the end of my presentation, I just want to say, though, that as a patient, beyond my personal experience, being involved in this project and helping to move it along is really, truly, truly rewarding, and it's something that the patients are very, very excited about and really want to be part of. So with that, I'm very happy to pass it over to Anne to describe the project further.
Oh, Anne, you're muted.
Yeah. Hi, everyone. I'm Dr. Anne Young. I'm a nephrologist at St. Michael's in Toronto. And I always thank Sue for sharing her story. I think it's a wonderful example of kidney disease care that went the right way, despite having the odds stacked against her. And perhaps on the opposite end is patients who are not necessarily getting care the right way. And patients are really at the heart of why we decided to do this project. And we've named it Kidney Care Outreach. And I'll talk to you about this very new and innovative pilot research study that we've decided to embark on with ICS. So to start off and to orient the audience, I really wanted to give some critical background so that you could understand the project a little bit better. So in the province of Ontario, the government collects routine information about the healthcare system and its use, and they collect that information to guide management and to pay for health services. So every time, so all of this information, it's called health administrative data. So every time someone visits a doctor, has a laboratory test, is hospitalized, or has a medication dispensed to them, and it all gets paid for by the government, that creates a new piece of health administrative data. All of that data gets linked together and it's stored at ICES. And ICS is this community of researchers, data, and clinical experts. We use the data to generate high quality evidence. And we also use that data to guide decision-making around healthcare policy and delivery. Right now, there's over 100 linked databases, and they go back to 1991 and over 18 billion health-related records. And so for scientists and researchers at ICS like us, for years, we've been performing research studies using all of the kidney function tests in Ontario. And based on those studies, we know that there are individuals in the province who are at high risk of kidney failure, and they aren't getting the care they need. We know they're not being seen by either family doctors or even nephrologists. And unfortunately, as physicians, we only meet them when they've declined to end-stage kidney disease, and we actually have to take care of them at that point. And based on the status quo, we really have not intervened for reasons of privacy and confidentiality of the data that we know exists. And so we ask ourselves, do we actually have a moral obligation to make sure that this doesn't continue to happen? And can we go beyond observing to actually helping people? So I won't get into all the nuances of how we did this, but we used ICS data to look into the province and see how many people are we really talking about. And what we found was that there are close to 1,500 people in the province of Ontario who have a very high risk of kidney failure, 1 in 4 chance of having kidney failure in the next 2 years, and they have not seen a nephrologist in recent history. And that truly their kidney care could be improved and their outcomes could be improved if they were well connected. So based on that, we asked, can targeted outreach of patients who are at high risk of kidney failure, who are identified using health administrative data, slow progression and reduce associated morbidity and mortality associated with kidney disease? And so we designed this research project called Kidney Care Outreach, and it basically can be broken down into 4 steps. I already talked to you a little bit about that first step, which is to identify individuals using the health administrative data. What's new and novel and exciting about this project is the following steps, where we actually, in appreciation of all the current privacy laws in the province of Ontario, we're going to take the next step to actually contact these high-risk individuals, assess their kidney health, and if indicated, refer them on to local kidney care. And we're doing this by sending personalized letters to individuals that we identify as being at risk. They get mailed and they're sent by ICS. The letter identifies them as someone whose kidney test results need further attention, and then we invite them to join a pilot research program that we're running, and they can visit a website. As part of the intervention that we're running, they are going to get new labs, including serum creatinine and urine albumin to creatinine ratio, which can give you an indication of how advanced your kidney disease is. They answer basic questionnaires about their health, and then they get a virtual assessment with a kidney specialist where we can confirm their chronic kidney disease, connect them with local care, and also provide additional support to understand a new diagnosis that they probably didn't know they had. And so to answer the question, what are we trying to achieve? We really want to launch a provincial safety net with kidney care outreach so that any at-risk people who are not getting the care they need, they are assessed in this way. They're caught by this safety net and they're seen as specialized kidney clinics so that they can get the care they need. And so that they're no longer out of sight, out of mind, or out of care. And the impact of this is really big. So by launching a program like this, we can actually minimize care gaps. We can make sure that the high-risk patients get the necessary care to slow down their disease. It's also a novel use of health administrative data that we haven't done before. There's certainly a lot of legal hurdles and challenges that we've had to come through, and we'll talk a little bit about that. But if this is really proof of concept, that if we can do this in kidney disease, it can really be applied more broadly to the management of a lot of other chronic conditions, or even or anything that has available data through health administrative data. And then finally, this work really is a stepping stone to guiding the modernization of privacy legislation. And we'll talk a little bit more about that. So with that, I'll pass it off to Nadia to talk more about some of these legal concepts.
Thank you, Anne. So that sounds like some very exciting work that you're undertaking. And I'm just going to bring us back to everyone's favorite topic of privacy and legal. At least it's my favorite topic. And really starting with PHIPA, which is Ontario's health privacy law, a Personal Health Information Protection Act. And it provides rules for the handling of personal health information in Ontario, which arguably is some of the most sensitive information that we can handle, and understandably requires a very strong framework to set out rules for the collection, use, and disclosure of this information to really accomplish a balancing act between protecting privacy of individuals, maintaining their trust in the healthcare system, but also recognizing that there is a need to share PHI among our healthcare system to really facilitate effective care. And I think we've seen an example of what possibilities that has by looking at Anne's research project. So PHIPA recognizes that information can be used for patient care, for planning and managing the healthcare system, for research projects, for quality of care, and really tries to balance these two. PHIPA is role-based legislation. So what does that mean, role-based legislation? Well, PHIPA generally applies to health information custodians. What's that term referred to in PHIPA? Typically refers to healthcare providers or physicians and hospitals, and how they handle your health information, when you go into a hospital, receive care. It also applies to many individuals and organizations that receive healthcare information from the custodian. And you'll see some examples from here, but many of you will be familiar with the researcher role, for example. And depending on what role you're playing under PHIPA and how you're using personal health information, PHIPA will permit you to use it for a certain purpose or share it for a certain purpose. It will also have certain restrictions and limitations on that ability. We have here this circle, an example is a service provider, an electronic service provider. An electronic service provider can be any organization that provides a custodian with an electronic service, such as an electronic medical record system or retaining their records in the cloud. And PHIPA will provide restrictions on how an electronic service provider can handle your information and what it can do with it. You'll also see in this circle a few prescribed roles, which in the legislation include named organizations such as Ontario Health or ICES, and provides them with very specific abilities to collect information from a healthcare provider without consent and use it for purposes such as health system planning or facilitating care or creating an electronic health record, very specific and limited purposes, and all under a very strict privacy and security regime that's overseen by the Information and Privacy Commissioner. So now we talk about the prescribed entity and what they can do and what does that mean? So health information custodians are permitted to disclose or share PHI with a prescribed entity without consent for the purposes of health system planning. And by health system planning, I mean that these organizations can collect information to come up with wait times reporting. Wait times reporting can be used by physicians and individuals to determine where they can receive care, or it can be used by the government to understand what services need to be funded or where resources need to be better allocated and to reduce wait times. So there's a number of health system planning purposes here that you can see that really affect change in the healthcare system and provide an increased ability to provide effective healthcare. And when we talk about those role-based legislations, prescribed entities also have the ability to wear different hats in that circle. For example, a prescribed entity under the legislation is permitted to act like it's a custodian so that it can use data for research and also share it for research. So we have a prescribed entity with a custodian hat that's now able to also use and disclose PHI for research purposes. So we talk about what a prescribed entity can do. I think it's equally important to really understand the limitations or the restrictions on what a prescribed entity may not do. Generally speaking, a prescribed entity may use the personal health information from a custodian only for health system planning and may not disclose it unless required by law. Now, there's exceptions, of course, to this general rule, but when we talk about restrictions, we're not able as a prescribed entity to share or use PHI with your physician or your doctor to make patient-level healthcare decisions. So even though a prescribed entity may have a large quantity of healthcare records, I think Anne mentioned 18 billion healthcare records, we have the ability to determine who might benefit from healthcare. We have limitations on the ability to share that with a healthcare with your healthcare provider. We also have limitations on contacting patients, except, for example, when we have that custodian hat on and when we're looking at patient contact research studies. So when we're looking at patient contact research studies, which is what Anne just went over in her example, we're looking at a prescribed entity such as ICES or Ontario Health and their ability to receive information from custodians and be able to share that with a researcher wearing that custodian hat. Now, it's important to note that even researchers are required to comply with many requirements under PHIPA because we don't want to forget about that balance between protecting privacy, protecting patients' trust in the healthcare system. And so it's quite heavily regulated. But at the same time, there's also some restrictions that can be difficult to navigate. So, for example, a researcher may not make contact with a patient until the custodian who provided that information first reaches out to the patient themselves to obtain consent. And when ICS or Ontario Health is wearing its custodian hat to share research information with a researcher, that job lies on us. So we then have to reach out to a patient who we may or may not have any relationship with, who may not have heard of us, to obtain their consent before that researcher can make contact. So with that, I will turn it over back to Anne to talk about some of the challenges.
Sorry about that. So this has been a project that we've been working on for the last 4 years to get it to where it is. And I'll just describe some of these challenges. So first off, I think the biggest challenge was truly understanding what is possible in the current form of PHIPA? And what is the legal authorities that we have in order for us to use ICS data to engage in patient contact? Now, this took quite a lot of effort from many people at ICES, Rosario, and many others who are included in this call, and direct communication and engagement with the Office of the Information and Privacy Commissioner of Ontario to get guidance on this, because it's really not extremely explicit, but that process in and of itself, we were able to sort out, but it did take quite a number of years to get it to that point. After we were able to get some guidance from the Office of the Information and Privacy Commissioner of Ontario, it did clear a pathway for us to be able to do this kind of work, but it remains extremely complex. Nadia discussed a few times now this concept of HATs, and we have HATs as a prescribed entity. We're acting as a health information custodian. At the same time, I'm a researcher. I'm also a physician. And there's this concept of trying to put on one hat at any one given time. And in truth, we all kind of wear multiple hats. And it's hard if you're trying to reach out to individuals who are potentially suffering from kidney disease to try to explain all of this to them in a way that they can understand without getting too technical, but at the same time saying, I really just want to help you, right? With all of these extra nuances. So extremely challenging, but with our protocol that we've designed with Kidney Care Outreach, we've designed a way to work through all of this in a protocolized fashion. And where there's a will, there's a way. So it is doable, just with complexity. Finally, the other issue that we came across was clear direction from the Office of the Information and Privacy Commissioner about how we couldn't go, if we had evidence to show that individuals were at high risk of disease, we really couldn't go directly to the ordering physicians who had ordered the test to show that they were at high risk. And it was decided that this would be considered a disclosure of personal health information. And so we even redesigned our entire project around contacting individuals first. But the challenging part is that as researchers, physicians, health information custodians, prescribed entities, we're all outside of the circle of care for any one of these individuals who we're contacting. And it makes it challenging when people who you don't necessarily know are coming to you and being like, by the way, you could get a little extra care for your kidney disease that you didn't know you had. So you can imagine the challenges that come around that. And if we were able to involve primary care providers or individuals who ordered the tests on these individuals, it could certainly make for a more seamless way to get them connected with care in a more trusted manner. So those are some of the major challenges that we've had to face. By modernizing PHIPA, some of these challenges could be addressed so that we can really change things in order to improve the healthcare of everyone in the province.
Thank you very much, Anne. That was terrific. And thank you to Nadia and Sue as well. So I have a couple of questions, but let me set the stage for everybody who's on the call. So we started off by providing the patient perspective and saying, to be proactive is really important when it comes to chronic kidney disease, but any disease across the board, really, that proactivity is important. Further, we heard from Anne, and Anne is working on this project very closely with Amit, with Dr. Garg, and the project is really testing a new kind of model. So it's looking to see, if patients were able to be identified early, what impact will that have overall across the health system, but also to the patient themselves. And then we also heard from Nadia, and Nadia talked about some of these legal challenges that impede the ability for prescribed entities to re-identify patients and inform them that they are at high risk of whatever disease. In this case, our use case is chronic kidney disease. So my first question then is to Nadia, is how, from your perspective, how does wearing multiple hats in PHIPA impede the ability to innovate or use health data for public good? Because we're talking about here PHIPA modernization, and the goal here is to see how can we modernize PHIPA to allow and to have a data-driven health system.
That's a great question, Rosario. And I think we really need to, well, one, recognize the purpose of all of those hats. And then the purpose of all of those hats is, the intention behind those rules is really to limit the ability to, collect, use, and disclose PHI wherever it's not required or wherever it's not, needed, in order to try to strike the balance between allowing those organizations to use it for specific purposes versus sharing it. But I think what it does is it just creates a lot of complexity and less flexibility in order to actually share it where it is needed. So when we look at the complexity of all of these different hats that Anne mentioned and the actual result that happens when you have to put on these different hats, the different very strict limitations, I think we need to really reevaluate whether or not it's actually striking the right balance between patient trust, and protecting privacy of individuals, where the intention of it is in place, and really our ability to provide effective healthcare.
That's great. And let me ask a follow-up question, because there's actually two questions in the chat that are somewhat related to the question I had in terms of the prescribed person model at Ontario Health. And so Ontario Health has multiple, so that's 3 different designations. Prescribed entity is one of them, but also a prescribed person in respect of the cancer registry. And so the question is, how can that designation be leveraged to re-identify patients who have chronic kidney disease, because that designation is much more about actually providing health care.
Exactly, Rosario. So folks may not be aware, but Ontario Health runs a cancer screening program. We operate this program as a prescribed person, which is one of those roles under PHIPA that I had previously shown. The prescribed person hat, as you mentioned, is much more focused on provision of healthcare. So under PHIPA, Ontario Health as a prescribed person is permitted to maintain a registry of PHI specifically for the purposes of providing healthcare. But I think that there is still some challenges while, looking at the prescribed person model versus the prescribed entity model that we need to really relook at. So a prescribed person model under PHIPA is restricted to one type of personal health information, like a registry specifically for Ontario cancer screening. Prescribed entities have the flexibility to collect information regarding not just a specific registry, but a number of different diseases. And so to continually go back and try to amend legislation to be flexible enough to be able to use PHI outside of that designated registry to facilitate care can be challenging and administratively burdened. So what we really are looking for is that, the best of both worlds, a prescribed entity where you can collect information about any disease, chronic disease type, or any other healthcare service, but all for analytics purposes, but then also the ability of a prescribed person, but
That's
maybe
right.
not as limiting. Yeah.
That's right. And so one quick follow-up, and I'll let others speak. I'll let Amit and Kareem, I think I saw your hand as well. So what are your thoughts on we have these 2 designations, prescribed person, prescribed entity, on the combination of such a designation in terms of looking at a data-driven health system? There are 2 separate designations. They existed back in 2004. Is there such a need perhaps to have 2 separate designations? Could you not have population-based analytics on one hand, helping to inform healthcare delivery on the other hand in a much more cohesive way? Exactly, Olive. That's exactly it. Yeah.
Absolutely. I mean, on one hand, you might consider some organizations that are prescribed entities may not have that need, but some organizations may have that ability to be able to combine those 2 functions to really affect healthcare. And those 2 designations follow very similar privacy and security framework. So it's almost like they're already set up to be, to follow a very similar governance framework and controls in place to make sure that PHI is only, being limited to be used for certain purposes. So I think that would be a great way to look at PHIPA modernization and really reevaluate whether some of those restrictions are really affecting change.
Excellent. So I'll turn it over to Kareem, who was first, and then Amit, and then I have a couple questions for Anne and Sue as well. So Kareem, over to you.
Yes, hi. Thanks very much. Excellent presentation by all. Very informative. I just wanted to go back to one of the slides. I may have misheard or misinterpreted. So a physician orders a test that is discovered that the patient has kidney disease. That results then goes back to the physician to explain that to the patient. Is the physician in a position to explain to the patient that you do have the disease and now you need to have the access to the following services? Would that be okay? Or is the physician not authorized to give that information to the patient?
Yeah, so I'll take that question, and I would say yes, the physician in that particular scenario is absolutely welcome to have that conversation, and I would imagine it's expected. I think where we run into struggles is where a patient might see a doctor or somebody who's not, they don't have a family doctor, so they might receive a lab test, through a walk-in clinic, but then they may or may not have a family doctor, and to be able to share information from a prescribed entity perspective, because we're the central kind of hub that's collecting information from all of these various sources, whether it's a walk-in clinic or administrative data sources that Anne mentioned, and then to share it even with the family, even with your family healthcare provider that's already in your circle of care. There's challenges and limitations to our ability as a prescribed entity to do that.
Thank you very much.
I'd also add on to that, that it's also in the interpretation of that data, right? So even though we can't redisclose that information because we don't know how that ordering provider interpreted that original information. So if as kidney specialists, we are seeing that data and we acknowledge it this way, they may not have interpreted it in that way. And so it's kind of like disclosing this new thing that they didn't know. And so as a result, it becomes a disclosure of information.
Amit?
Yeah, and a few things to add. As a part of this project, we strongly support strengthening primary care. Of course, we want that to happen. And when we're flagging people with care gaps, as mentioned, people may have these tests done through walk-in clinics, so they emerge and they may not have primary care even physicians. And we need to fix that in Ontario, of course. And we do note in the data that even sometimes when there is a primary care physician involved, there's still, for whatever reason, a care gap occurring. Now, is that because on the patient side and they have social determinants of health that needs more support to make this happen, or is it that they it wasn't recognized? Because it can be a bit subtle early, not even early. Some kidney function tests get misinterpreted. Like, it's not like you have cancer. It's like the test tells you that. It tells you this is your value. You have to look at a number of things, so they can be misinterpreted. And then some of the tests actually just practically, there's a blood test that we use, but also you can stratify risk better with, you also have a urine test. And so through this study, but even you can imagine, you can do new modeling to predict where tests don't even necessarily exist, but just based on the other parameters of the health profile you have at ICS, you can identify this person's still likely at high risk. And so we've done some of that a little bit in this setting as well. The other thing I just wanted to highlight is that also there's this, we were talking about a prescribed person, prescribed entity. There's also, is this research, is this just care delivery, is it quality improvement? This is being done under a research framework for a few reasons. One, we were given guidance by excellent colleagues who were involved in the early days of the cancer screening program, where, as to orientate everyone, we get notified when you're due, the public, myself included, gets notified when we're due for cancer screening, you're due for colorectal cancer screening, etc. But that did start as a research framework, and that maybe is a good thing, because we're still trying to show the value, make sure that have all positive consequences, no unanticipated negative consequences before it actually becomes policy. If you do it in a research framework, as mentioned, you already have research ethics board approval, and for this particular project, we went through our Western approval, and we do have Clinical Trials Ontario, but just given the nature of this project, REB did the extra step of consulting all the REBs in the province just to make sure what we're doing was reasonable. And so that was an additional level of oversight occurred here. Involving the public is really important. So in terms of our engagement and advice process, which is still ongoing, ICS is a citizen and patient council, like so we, I might not have the right term for that, but it's like a citizen panel. So we presented there and we got great advice. We presented to the Ontario Renal Network. So I previously had a medical lead role in the Ontario Renal Network. I have a lot of close colleagues there. They have full visibility on this project. They strongly support the project. After in detailed consultation with the leadership, they felt also it was the right approach to do this initially as research. And then once we prove the value, we would adopt it as a policy, just like as it's done in cancer care. The Auditor General of Ontario has identified that we should be using lab tests in a more refined way to like fix care gaps. They identified this as a recommendation as well. And then when you do it in a research framework, also just in terms of additional levels of oversight, we do have a data safety and monitoring board that has an additional level of oversight, just because there's so many considerations here. And then finally, this may come up based on the nature on how we are contacting patients first. There are many considerations in the project, but one of them is the relationship between that patient and their, let's say they do have a primary health provider. Imagine you have a situation where you have a primary healthcare provider and they were aware of the test, but they misinterpreted, nothing to do with the patient side, but it is misinterpreted, mishandled. And this is actually one of the motivations actually for the cancer screening. Historically, there were situations where cancer tests weren't done, or when they were done, the results weren't followed up on. And so this was one of the motivations to have this extra layer that the public's also aware. So we have to be very mindful that we don't want to erode trust in any way between the primary care physician and the patient we're contacting who may be at risk. And so doing that in a very responsible way is important. But we've heard also loudly and clearly that if any of us on this call was at risk of a serious health condition, we weren't aware of it, we don't want to know that too. Like we just don't want it to be not known. So it's this very delicate thing that we're trying to manage, and we are doing detailed consultations with primary care leadership as well, just to make sure we have that right.
And so let me just pick that up, and I know that there are comments, and so I'll be going to those as well. And it goes to some of the questions that were being asked in terms of the prescribed entity model, and to bring it back to PHIPA modernization. So within, Ontario Health as an agency of the government, there are certain data that are collected by the agency. As a prescribed entity, ICS has other data holdings. We heard about the data holdings that ICS has for population-based analytics. And the other two prescribed entities would have other data based on their, the work that they do. And so what we wrote in the report, so we use the use case of chronic kidney disease, but we also have another use case in respect of opioid use. And so the question that we're putting out there is, to what extent do we need to have two different types of designation for these types of purposes? To what extent, it's a question that's out there. Is there an opportunity to amalgamate some of those, because one entity has population-based data and can identify those patients upstream, as we've discussed, ensuring, of course, that we have the proper privacy and security frameworks in place, and we continue to have the trust of patients. And so with that, one of the questions that was in the chat is, how do you address the moral obligation to inform individuals of information that would avoid harm? I mean, I think the conversation was about feeling that moral impulse to inform early on. Maybe Anne or Amit, do you want?
So I'll try to take a crack at that one. So I kind of mentioned this whole concept of us seeing all this data, knowing that it's there, sitting by and not doing about it, and this moral obligation. And I don't think it's a feeling that comes just from the researchers who are seeing this data. As part of this research project, we've actually conducted focus group work to ask people in the general population, as well as individuals who have lived experience with chronic kidney disease, about this concept of using data in this way. And I'll also acknowledge that many of my co-authors are actually in this audience today. But the sentiment that we had from this focus group work was that if the province has the ability to identify specific individuals who are at high risk, particularly for potentially life-threatening illness, and that illness could be treated and caught early enough, there actually is a ethical imperative and a social responsibility that we should be notifying these people. And it actually, people even went as far as to say that it would be unethical not to do it. So I think the sentiment is out there across the board from care providers, from the general public, from people with lived experience. So I think it gives us more motivation to try to do this kind of work.
Maybe just add to
maybe you'll add to that.
Yeah, add to that. Like Nadia framed it very well. Like there's very sensitive information in these data sets, right? Like I give extreme examples. There's mental health visit information. There's abortion information. There's all these types of information in there. So we have to be very, very careful and mindful whatever we do. But ask yourself also, like, suppose you developed, any of us on this call, developed a serious health conditions 5 years from now. And suppose there are treatments to prevent that health condition. And suppose you learned there was some organization, both Ontario Health and ICS, who had this information. They even flagged you, but they could only report an aggregate and wave their hands and write a report that there's a problem. And then if they would have contacted you 5 years ago, you would have then been flagged as being at risk. You would have gotten treatments and you wouldn't have this outcome now 5 years later that you're really suffering from. Like anyone on this call would say, well, that's just wrong. Like you could have helped me and you just sat on it and you didn't do anything. Like, so it is very delicate. We have to get the right balance, but this is what you're getting at. Everyone, Rosario, you're getting at. We all would feel that way. Like if you could have prevented this 5 years ago, you flagged that this was a problem and you just let it, you just stood by and did nothing about it. Or you did it like general, like we have a problem in the system, so let's strengthen primary care. Of course we're gonna do that. But the safety net you had in place where you flagged me and you saw that I wasn't getting the right care, of course you're just strengthening healthcare in general, of course, but why didn't you reach out to me specifically and tell me I was gonna have this major serious problem 5 years, now I have it. Like, what do you think, Rosario? Again, I'll turn it back to you.
Well, no, and certainly, well, I've had the privilege to work on this project now for about 5 years, so I very much understand the need to think about how we do this in our statute in a way where, I mean, certainly to the point that Amit made, I mean, we go to great lengths to ensure that there is no risk of re-identification, looking at small cells and ensuring it's not possible for anybody who has access to these to the reports to be able to re-identify. So I very much I agree with the sentiment that we need to do something about it in modernization. And so, sorry, go ahead, Amit.
Sorry, I just wanted to make the point. I was also coming in the chat. You're using a certain algorithm which has been fairly sophisticatedly proven in regression analyses with certain tests to identify people at risk. But you can now do this in more sophisticated ways. We have lots of data. You know, there's different prediction models, both regression-based AI models, a number of other models. And so our ability to do this is going to get stronger and stronger for multiple conditions. So it's really a wonderful time to talk about this because over the next decade, there'll be a lot of serious diseases where we'll have pretty good sophistication given all the significant data we have on people at ICS and at Ontario Health to be able to create fairly reliable models of someone who's going to be at really serious risk of an adverse event or a poor outcome in several years earlier than it actually before it occurring. And also because we have health service data, we can also see there's clearly a care gap and they're not getting the treatments that's going to prevent this outcome. So this is going to happen more and more over the next decade, next 2 decades for sure.
That's right, Amit. And maybe I'll turn it over to Sue for some thoughts as well, because as you know, as a patient, and we're certainly talking about patient-centered care when it comes to Ontario's health system, and the notion of, you know, a prescribed entity or a prescribed person being a trusted data steward of Ontarians' data is a really fundamental one that we really take to heart and use that as our point of reference when it comes to decision making at our organizations. So to what extent would you say that the type of model that we're looking for would balance the erosion of trust in the health system or you know, the trusted data stewards model? Do you see that there can be a way to reconcile both so that ultimately, You know, as Amit said, you know, we're seeing more and more predictive algorithms. We know that there's population-based data. What are your thoughts on the discussion from a patient perspective?
Yeah, no, thank you so much. I think this is transformational work. This is from a patient perspective, and we have a number of patients working on this. This is tremendously exciting to see data used in this way. Anne made the point earlier that sometimes nephrologist is going to interpret the data differently than the GP. And, you know, in my brief introduction, I described how my GP for many years interpreted very differently than the minute a nephrologist saw it. And I would not, had I not been the person to push, I would have never received the care that I did. And I think that that's why it's so great that, you know, to have a system where our information is being looked at by multiple people that can see what the real challenges are and can get us the care that is going to make a difference in terms of how we live our lives and our futures. I mean, this is critical. And, you know, if more people can have the outcome that I was able to have, that success, you know, because their caregivers are working together to look at all of the information and provide the best outcomes. It's a great balance in my view.
Great, thank you very much. And thank you to our panelists. Thank you to Dr. Young, and thank you to Dr. Garg and to Nadia and Sue for joining us over the noon hour. Thank you to our participants as well. I saw there are many questions in the chat. We'll respond to some of them as we go throughout the course of our day. And thank you as well to everyone who participated, our Public Advisory Council certainly, and others at ICEA to help draft this written submission to the ministry. Thank you very much, and look forward to more thought leadership pieces with all of you. Take care. Have a great day. Bye.